I'm Josephine De La Serna and I'm a pediatric cardiologist. Today we are going to talk about cardiac diseases. I have divided my lecture into 5 parts. We will start in understanding the fetal circulation, then its transition to the neonatal circulation. This way you will be able to understand the physiology of the development of congenital heart disease. I will take up also the most common congenital heart diseases, which are ventricular septal defect, patent ductus arteriosus, and tetralogy of Fallot. I will not discuss anymore the other congenital heart diseases. You will just read on it. The other topic that we will discuss is heart failure and other acquired heart diseases such as infective endocarditis and Kawasaki disease. So we will start with the fetal circulation. The fetal circulation is described as a parallel circuit as compared to a series circuit in the neonate and adult. There are 3 cardiovascular structures maintaining the parallel circulation, and these are the ductus venosus, foramen ovale, and ductus arteriosus. Ductus arteriosus is maintained patent due to the low oxygen tension and endogenously produced prostaglandins during fetal life. The placenta is where gas and metabolite exchange occur as compared to the lungs. The lungs in the neonatal stage is the organ for gas exchange. However, in the fetal stage, the organ for gas exchange is the placenta. The highest level of PO2 going to the fetus is only 30 to 35 millimeters of mercury, since the placenta is not as efficient exchange organ compared to the lungs. 50% of the umbilical venous blood enters the hepatic circulation, and the rest bypasses the liver, then to the inferior vena cava through the ductus venosus, where it mixes with poorly oxygenated inferior vena cava blood from the lower part of the fetal body. So that the combined lower body plus umbilical venous blood flow is about PO2 of 26 to 28 millimeters of mercury. The combined lower body plus umbilical venous blood flow goes to the right atrium and is preferentially directed by a flap of tissue at the right atrial inferior vena cava junction, and this is called the Eustachian valve, then across the foramen ovale to the left atrium. This is actually the major source of left ventricular blood flow, as pulmonary venous return is minimal. Left ventricular blood is then ejected into the ascending aorta, where it supplies predominantly the fetal upper body and the brain. So let us go now to the fetal superior vena cava. Fetal superior vena cava blood is considerably less oxygenated with a PO2 of 12 to 14 millimeters of mercury. It goes into the right atrium, then preferentially flows across the tricuspid valve instead of the foramen ovale, then to the right ventricle, then into the pulmonary artery. But since the pulmonary arterial circulation is vasoconstricted, only 5% enters the lungs and the major portion is shunted through the ductus arteriosus into the descending aorta to perfuse the lower part of the fetal body and the placenta through the 2 umbilical arteries. So, the upper part of the fetal body, including the coronary and cerebral arteries, and those to the upper extremities is perfused by the left ventricle, and the lower part of the fetal body is from the right ventricle. This is a diagram that shows numbers that represent percentage of combined ventricular output. The venous return comes from the superior vena cava, which is 21%, and inferior vena cava, which is 69% of the total venous return. About 66% goes to the right ventricle and only 7% goes to the lungs, and the greater volume is shunted to the patent ductus arteriosus to the descending aorta. On the other hand, only 27% of the blood in the right atrium enters the PFO. Then to the left atrium, combined by blood from the pulmonary vein. Then 34% goes to the left ventricle. 3% flows to the coronary arteries. Then the rest, which is 31%, goes to the ascending aorta. 21% goes to the neck vessels supplying the brain and the upper extremities, and only 10% of fetal cardiac output flows all the way into the aortic arch to the descending aorta. The combined output of both the left and right ventricle is 450 milliliters per kilogram per minute. About 65% of the descending aortic blood flow returns to the placenta, and the remaining 35% perfuses the fetal organs and tissues. During the fetal life, the right ventricle is pumping against systemic blood pressure and also performs a greater volume of work than the left ventricle. At birth, there is a rapid decrease in pulmonary vascular resistance due to the rapid expansion of the lungs and an increase in arterial PO2. At the same time, the removal of the placenta leads to an increase in systemic vascular resistance, so the right ventricle pumps entirely to the pulmonary circulation. And during this time, systemic vascular resistance becomes higher than pulmonary vascular resistance, causing a reversal of flow across the ductus arteriosus from right to left to right. And during the 15th hour of life and a couple of days, the arterial PO2 closes the ductus arteriosus, which becomes the ligamentum arteriosum. The closure of the foramen ovale is due to the increased volume of pulmonary blood flow returning to the left atrium from the lungs, which increases left atrial volume and pressure. Moreover, the removal of the placenta closes the ductus venosus. So let's now proceed to the neonatal circulation. In the neonatal circulation, the venous return is through the inferior vena cava and superior vena cava. Then it goes to the right atrium, through the tricuspid valve, then to the right ventricle, to the pulmonary valve, to the pulmonary artery, then to the lungs, to the pulmonary veins, to the left atrium, through the mitral valve, to the left ventricle, then to the aortic valve, then finally out into the aorta. Since the left ventricle is already pumping against a high systemic vascular resistance, the left ventricle thickens. Oppositely, the right ventricle thins out due to the low pulmonary vascular resistance. The newborn cardiac output is approximately 350 milliliters per kilogram per minute, and it falls in the first 2 months of life to 150 milliliters per kilogram per minute, and then more gradually to the normal adult cardiac output of approximately 75 milliliters per kilogram per minute. There are differences between a neonatal circulation and older infants. The first is right to left or left to right shunting may persist across the patent foramen ovale. Second, in the presence of cardiopulmonary disease, Continued patency of the ductus arteriosus may allow left to right, right to left, or bidirectional shunting. Third, the neonatal pulmonary vasculature constricts more vigorously in response to hypoxemia, hypercapnia, and acidosis. Fourth, the wall thickness and muscle mass of the neonatal left and right ventricles are almost equal. And finally, fifth, newborn infants at rest have relatively high oxygen consumption, which is associated with relatively high cardiac output. So now, how do we evaluate those suspected to have cardiac diseases? The following are the more common cardiovascular complaints. The heart murmur is the most common complaint seen in the clinics. Majority of the murmurs heard in children are innocent or functional, or these are murmurs with no underlying structural abnormality and function, and these are not hemodynamically significant. Another cardiac presentation is cyanosis. Sometimes it is difficult to determine whether cyanosis is due to a pulmonary or a cardiac cause. One very good way of determining that a patient has a cardiac cause of cyanosis is when the patient has central cyanosis or cyanosis seen in the lips, buccal mucosa, and nail beds. Different age groups might present with different symptoms like intermittency of feeding, diaphoresis when sucking, recurrent lower respiratory tract infection, and dyspnea. These are more common in infants. In older children, there is failure to thrive and exercise intolerance. Perinatal history is paramount to evaluation of cardiac disease. Maternal gestational diabetes, teratogenic medications, systemic lupus erythematosus, and substance abuse are associated with cardiac lesions. If there are symptoms, it is important to know when the symptoms started. Like for example, if a patient presents with cyanosis, you have to know when it started or when it was first noted because the timing of the cyanosis will give you a clue to your differential diagnosis. And of course, congenital malformation and chromosomal abnormalities are commonly associated with cardiac diseases. Congenital heart disease may be due to a couple of maternal predisposing factors. This table shows the associated defects due to maternal factors. One of the more common association is the rubella in the mother and having an infant with peripheral pulmonary stenosis or patent ductus arteriosus, or diabetes in the mother having an infant with hypertrophic cardiomyopathy or transposition of the great arteries, or a mother with systemic lupus erythematosus having an infant with complete heart block. This table shows chromosomal abnormalities associated with congenital heart disease. The more common one is the trisomy 21 or the Down syndrome. This is associated with complete atrioventricular septal defect. After history taking, a complete physical exam is important. You have to determine whether there is failure to thrive, thus the importance of always plotting the child's growth curve. Or are there signs of cardiac and respiratory distress? Taking the vital signs like the heart rate, respiratory rate, including pulse oximetry, is important. An increase in heart rate and respiratory rate with no background of infection might mean that there is heart failure. On inspection, note for the point of maximum impulse where it is located, and note for precordial bulge, Harrison's groove. Feel the patient's chest and determine presence or absence of frill or heave. Percussion has limited value in pediatric patients due to the thinness of the chest. Auscultation entails determining the rate and rhythm, listening for the heart sounds whether it is distinct or not, listening for the character of the S1 and S2, or presence or absence of extra heart sounds. And of course, the presence or absence of a murmur. We will discuss further how to describe a murmur. The features of a murmur include, well, it actually has a mnemonic called script, S for sight, C for character, R for radiation, I for intensity, P for pitch, T for timing. In infants and children, the location of the murmur is stated as upper sternal border, left upper sternal border, left lower sternal border, and apical area due to the small chest of the child. Unlike in adults where we say second intercostal space mid-clavicular line or fourth intercostal space at the parasternal area and so on. And of course, the intensity of the murmur should be included. We grade them 1 to 6 depending on the softness or loudness of a murmur. Grade 1 is barely inaudible and grade 6 being inaudible with a stethoscope off the chest. Grading of murmur is automatically 4 when a thrill is palpated. We use the bell of the stethoscope when we listen to a low-pitched murmur like that of mitral stenosis. We use the diaphragm to listen to a high-pitched murmur like that of aortic regurgitation or mitral regurgitation. Murmur is further characterized by its timing, whether it is systole or diastole. Systole would mean closure of the atrioventricular valves, whereas diastole is the closure of semilunar valves. Murmurs heard on systole is heard between S1 and S2 and may be due to an aortic, pulmonary stenosis, or mitral or tricuspid regurgitation. Murmurs heard on diastole is heard after S2 and before S1, and it may be due to an aortic or pulmonary regurgitation, mitral or tricuspid stenosis. Aortic stenosis, pulmonary stenosis, and atrial septal defect has a systolic ejection type of murmur. So this is how it sounds. So you hear the first heart sound before the blowing sound, then the second heart sound. So when you hear this murmur located at the right upper sternal border, it is aortic stenosis. In the left upper sternal border, it is pulmonary stenosis. So let us listen to it again. When you hear a murmur throughout systole, or what we call a holosystolic murmur, and it is located at the apical area, it is mitral regurgitation. And when heard at the lower left parasternal border, it is called tricuspid regurgitation or ventricular septal defect. Notice that you barely hear the first heart sound since the murmur is pan-systolic. Let us go now to diastolic murmur. Mid-diastolic murmur heard at the apical area is due to a mitral stenosis. You hear the murmur after the second heart sound. Let us listen to it. Again, continuous machinery type of murmur heard at the left upper sternal border is due to a patent ductus arteriosus. This is how it sounds like. Again, after the physical exam, one should already have a clue of what cardiac lesion you are dealing with. Diagnostic tests are done to confirm or rule out your differential diagnosis. A chest X-ray is done to determine whether there is chamber enlargement or which chamber is enlarged. The cardiothoracic ratio is an important measure to determine presence or absence of cardiomegaly. The most frequently used measurement of cardiac size is the maximal width of the cardiac shadow in a posterior-anterior chest film taken mid-inspiration. A vertical line is drawn down the middle of the sternal shadow, and perpendicular lines are drawn from the sternal line to the extreme right and left borders of the heart. The sum of the lengths of these lines is the maximal cardiac width. The maximal chest width is obtained by drawing a horizontal line between the right and left inner borders of the rib cage at the level of the top of the right diaphragm. When the maximal cardiac width is more than half the maximal chest width, or a cardiothoracic ratio of greater than 50%, the heart is usually enlarged. In the posterior-anterior view, the right cardiac silhouette is formed superiorly by the superior vena cava and inferiorly by the right atrium. The left border of the cardiac shadow consists of three convex shadows produced by the aortic knob, the main and left pulmonary arteries, and the left ventricle. The left atrial appendage is between the pulmonary artery and left ventricle. Left atrial enlargement is seen when the left atrium is prominent on the left cardiac border, which can be seen as straightening of the cardiac waistline. There is left ventricular enlargement if there is downward displacement of the apex, and on the lateral view, there is obliteration of the retrocardiac space. Right atrial enlargement is seen if there is increased prominence of the lower right cardiac silhouette. Right ventricular enlargement is seen when there is obliteration of the retrosternal space on lateral view. One of the major goals of doing a chest X-ray is the assessment of the pulmonary vascularity. There is increased pulmonary vascular markings if the pulmonary artery is enlarged and vascularity extends into the lateral third of the lung field. Decreased pulmonary vascularity if the hilum appears small and the lung fields appear black. Another diagnostic test used is the electrocardiogram. It is a test that measures the electrical activity of the heart. This is a very important diagnostic tool in determining heart rate, abnormality of rhythm, and determining the relative sizes of the chambers. The different waves in the ECG are the P wave. This is the atrial depolarization. QRS complex, which is ventricular depolarization. T wave, which is ventricular repolarization. PR interval, which is the start of the atrial depolarization to the start of ventricular depolarization. ST segment, where the entire myocardium is entirely depolarized. QT interval, which is the start of ventricular depolarization to the end of ventricular repolarization. You can just read on how to read an ECG, since ECG reading needs a separate session of lecture. Another diagnostic test is the 8 to 24-hour Holter monitoring. It is a continuous test to record your heart rate and rhythm for 8 to 24 hours. Abnormal heart rhythms and other types of cardiac symptoms can come and go and may not be detected with 15 leads ECG alone. Ambulatory ECG is useful in detecting arrhythmias, knowing if an arrhythmia gives rise to symptoms, and determining whether there are precipitating or terminating events. Monitoring for a longer period of time is necessary to record these events. The gold standard for diagnosing congenital heart disease and acquired heart disease is the echocardiogram. It uses sound waves that travel in straight lines and produce echoes when deflected by solid or liquid media. It is like doing an ultrasound of the heart. The intracardiac and extracardiac structures are visualized on 2D echo. Gradients can be measured across valves, shunts, or vascular structures. Abnormal flow patterns are also seen in 2D echo. Echocardiography can also be used doing procedures like balloon atrial septostomy or pericardiocentesis. Another diagnostic test is exercise testing. It measures the heart rate, electrocardiogram, and blood pressures to provide detailed information on the cardiovascular, pulmonary, and muscular systems. This testing allows an accurate quantification of functional capacity, measure of exercise tolerance, diagnosis of cardiopulmonary disease, disease progression monitoring or response to intervention, and the prescription of exercise and training. Nuclear cardiology is an imaging test that uses radio waves, magnets, and a computer to create a detailed picture of your heart. Nuclear angiogram and cardiac MRI is useful in visualizing blood flow and detailed anatomy of the heart. Cardiac catheterization, which is available in Cagayan de Oro, is used for hemodynamic studies of the heart, like determining shunt volumes and intracardiac pressures. Anatomy of the heart is also well visualized in cardiac catheterization. Different interventional procedures can also be done, like PDA device closure, ASD and VSD closure, PDA stenting, and balloon atrial septostomy. Cardiac computed tomography imaging and angiogram modality improves the visualization of some structures not clearly seen on 2D echo, like the coronary arteries, pulmonary arteries, and branches of the aorta. I will just show you an algorithm on how to diagnose congenital heart disease. If you are able to memorize this table, it will be very easy for you to diagnose what congenital heart disease you are dealing with. For starters, it is important to determine if you are dealing with a cyanotic or a cyanotic heart disease. Cyanosis is usually clinically detected if the oxygen saturation is less than 85% and if the concentration of deoxyhemoglobin is at least 5 grams per deciliter. Oftentimes, it is difficult to determine if you are dealing with a pulmonary or a cardiac disease. A very useful test is by doing hyperoxic test, which is done by measuring the arterial blood gas of the patient while they breathe room air, then measuring the blood gas after the patient has breathed 100% oxygen for 10 minutes. If the PO2 is greater than 150, then the cause is pulmonary. If the PO2 is less than 150, then the cause is cardiac. Next is to determine whether there is evidence of increased pulmonary blood flow or decreased pulmonary blood flow. This can be documented by a chest X-ray. Of course, it is important to know which chamber of the heart is enlarged, whether it is left ventricular hypertrophy or right ventricular hypertrophy or biventricular hypertrophy. So if you are dealing with an cyanotic cardiac lesion with increased pulmonary vascular marking and right ventricular hypertrophy, the differential diagnosis would be atrial septal defect, partial anomalous pulmonary venous return. When the left ventricle is enlarged, the differential diagnosis would be ventricular septal defect, patent ductus arteriosus, or aortopulmonary window. If you are dealing with a cyanotic cardiac lesion with normal or decreased pulmonary vascular markings, most probably you are dealing with an obstructive lesion such as pulmonary stenosis and aortic stenosis. However, when you are dealing with a cyanotic cardiac lesion with increased pulmonary blood flow and right ventricular enlargement, you might be dealing with a transposition of the great arteries, total anomalous pulmonary venous return, or double outlet right ventricle without pulmonary stenosis. If there is left ventricular hypertrophy, the lesion may be truncus arteriosus. When you are dealing with a cyanotic lesion with normal or decreased pulmonary blood flow with right ventricular hypertrophy, the differential diagnoses are tetralogy of Fallot, double outlet right ventricle with pulmonary stenosis, and Epstein anomaly. If you have left ventricular hypertrophy, the cardiac lesion may be pulmonary valve atresia with intact septum and tricuspid valve atresia. I will not discuss all the congenital heart diseases. I will only discuss the most common ones. Let us start with ventricular septal defect. VSD accounts for 25% of congenital heart disease. It has different types, which are perimembranous, which is the most common type, the inlet, the outlet, and the muscular type. The size of the ventricular septal defect determines the size of the left to right shunt. The level of pulmonary vascular resistance in relation to systemic vascular resistance determines the shunt's magnitude. The picture shows a hypothetical representation of the pathophysiology of VSD. The encircled numbers are the saturation of blood inside the cardiac chambers, and the other numbers are the liters of blood that flow through the cardiac chambers. The oxygenated blood goes to the right atrium, through the tricuspid valve, then to the right ventricle. Oxygenated blood is shunted from the left ventricle to the right ventricle through the VSD. This increases the volume of blood going to the lungs. From the lungs, blood is fully oxygenated, and the same volume of blood goes to the pulmonary veins, then to the left atrium, through the mitral valve, to the left ventricle, to the aortic valve, then to the aorta. At birth, pulmonary vascular resistance may remain elevated, thus the size of the left to right shunt is less. Because of the normal involution of the media of small pulmonary arterioles, pulmonary vascular resistance begins to fall in the first few weeks after birth, and the size of the left to right shunt increases, thus the appearance of signs and symptoms. Patients with a small ventricular septal defect are asymptomatic with normal growth and development. It can be discovered during routine physical exam with an auscultatory finding of a loud holosystolic murmur and with presence of thrill. Patients with large ventricular septal defect have heart failure signs due to excessive pulmonary blood flow, such as dyspnea, exercise intolerance, diaphoresis, feeding difficulties, and failure to thrive. On physical exam, there is laterally displaced apical impulse and apical thrust. There is presence of precordial bulge and Harrison's groove, and presence of systolic thrill. The second heart sound may be accentuated due to the pulmonary hypertension. A holosystolic murmur is heard at the left lower parasternal border. On chest X-ray, those with small VSDs may appear normal, may have minimal cardiomegaly, or increased pulmonary vasculature. The ECG may also appear normal or may have left ventricular hypertrophy. Those with large VSDs have X-rays showing cardiomegaly, left atrial enlargement, left ventricular enlargement, prominence of the pulmonary artery, increased pulmonary vasculature, or presence of pulmonary edema. Two-dimensional echocardiogram is very useful in showing the position and size and number of ventricular septal defect. It is also used to estimate right ventricular pressure and pulmonary arterial pressure. It also shows presence of aortic valve insufficiency or aortic leaflet prolapse. When laboratory data do not fit well with the clinical findings or when pulmonary vascular disease is suspected, cardiac catheterization is done. This procedure will help determine the hemodynamics of VSD. Small restrictive VSDs are associated with normal right heart pressures and pulmonary vascular resistance. Large, non-restrictive VSDs are associated with equal or nearly equal pulmonary and systemic systolic pressure and variable elevations in pulmonary vascular resistance. This accurately measures pulmonary arterial pressure. 30 to 50% of small defects close spontaneously during the first 2 years of life. Small muscular VSDs are more likely to close than membranous VSDs. Majority of defects close before the age of 4, but not beyond 8 years old. Management has two aims. First is to control symptoms of heart failure, and second is to prevent the development of pulmonary vascular disease. If, with signs of heart failure medications are given, such as diuretics, digoxin, and ACE inhibitors. Supplementation is also important to increase high caloric content and increasing frequency of feeding. There is actually no exercise restrictions required in the absence of pulmonary hypertension. Since antibiotic prophylaxis is no longer recommended for dental visits, dental hygiene is very important. Indications for surgery include large defects with uncontrolled heart failure, infants 6 to 12 months of age with pulmonary hypertension, older than 24 months with QPQS ratio greater than 2:1, and supracrystal VSD. VSD device closure can be done with those perimembranous and muscular type, but contraindicated in supracrystal, inlet, and those with associated significant aortic regurgitation, prolapsed aortic cusp, subaortic cusp, subpulmonary, subpulmonary stenosis, and Eisenmenger syndrome. After the surgery, the precordium becomes adynamic, cardiac size decreases, thrills and murmurs disappear, and there is regression of pulmonary artery hypertension. Catch-up growth is within 1 to 2 years. Let's go now to patent ductus arteriosus. PDA occurs in about 5 to 10% of all congenital heart diseases, excluding premature infants. It is more common in females than males. It is a common problem in premature infants. When in term infants, there is deficient mucoid endothelial layer and muscular media. Presence of PDA is due to the persistence of its patency beyond fetal life. This structure connects the pulmonary artery and the descending aorta. The blood is shunted left to right due to the high pressure in the aorta compared to the pulmonary pressure. The size of the shunt also depends on the size of the PDA. Patients are usually asymptomatic when the ductus is small. Those with large PDA have heart failure signs such as intermittent feeding, recurrent pneumonia, exertional dyspnea, and failure to thrive. On physical exam, there is a continuous machinery murmur with bounding pulses. The ECG of a patient with a large PDA usually shows tall R wave on V5 and V6, indicating left ventricular enlargement, and also with notched P waves indicating left atrial enlargement. The X-ray would show left atrial enlargement, left ventricular enlargement, prominent pulmonary artery, and increased pulmonary vascular markings. This is how it looks like in echocardiogram. With large PDAs, the left atrium and left ventricle are dilated. The red color in the picture shows the appearance of PDA on echocardiogram. The clinical signs and echocardiogram is already sufficient to accurately diagnose patent ductus arteriosus. Cardiac catheterization may be indicated to confirm diagnosis, and of course to check for pulmonary arterial pressure. Interventional catheterization has been the trend now in the closure of patent ductus arteriosus, since it is less invasive and hospital stay is less. And of course, there will be no intensive care admission. The case fatality rate of interventional or surgical treatment is considerably less than 1%, and the risk without intervention or surgery is greater. Asymptomatic or symptomatic patients with PDA should have closure already, ideally before 1 year of age. Patients who develop pulmonary hypertension should still undergo intervention, whether device closure or surgical closure, as long as hemodynamic studies shows that the shunting is still predominantly left to right. After the intervention or surgery, symptoms of heart failure disappear, the heart usually returns to its normal size, and there is catch-up growth. Usually, in a term infant, closure of PDA is rare. Small PDA may have normal lifespan with a risk of developing infective endocarditis, and those with large PDA without intervention will continue to have heart failure signs and also risk of infective endocarditis. Patent ductus arteriosus should be closed due to the risk of complications. And these are infective endocarditis, pulmonary or systemic emboli, aneurysmal dilation of the pulmonary artery, non-infective thrombosis of the ductus with embolization, and pulmonary hypertension. So we go now to tetralogy of Fallot. The primary and important defect that brings about the components of TOF is the anterior deviation of the infundibular septum, which causes obstruction to the right ventricular outflow or infundibular pulmonary stenosis, malalignment type of ventricular septal defect, overriding of the aorta, and right ventricular hypertrophy. As the right ventricle contracts and with presence of marked pulmonary stenosis, the deoxygenated blood goes to the pulmonary artery across the pulmonary valve. But since there is a large VSD, which makes the systolic and diastolic pressure for both ventricles similar, some of the deoxygenated blood is shunted from the right to the left ventricle without passing through the lungs, and the blood joins the oxygenated blood coming from the lungs, going to the pulmonary veins, left atrium, and left ventricle. Thus, blood pumped out of the aorta is desaturated. The degree of right ventricular outflow obstruction determines the onset of symptoms and severity of cyanosis. That is why it is important to know when the cyanosis started. Most of the time, in TOF, cyanosis is apparent after a few months of life due to the worsening of the pulmonary stenosis. But in some cases, when cyanosis is already seen during the neonatal period, it means that there is already severe right ventricular obstruction to start with. And oftentimes, when the right ventricular obstruction is severe at birth, there should usually be a patent ductus arteriosus that would augment the severely diminished blood flow to the lungs. Other signs and symptoms that the patient would have are gray sclerae with engorged blood vessels, dusky blue skin, clubbing, dyspnea and exertion, squatting position for the relief of dyspnea. A boot-shaped heart is seen in the X-ray of a patient with TOF due to the upturning of the apex, which is a sign of right ventricular hypertrophy and hypoplasia of the pulmonary artery. There is also decrease in vascular markings due to the decreased blood flow to the lungs. The ECG would show right axis deviation, tall R waves, and or RSR pattern on V3R and V1, or deep S wave on V5 and V6, which would mean that there is right ventricular hypertrophy. There may also be peak T wave due to right atrial enlargement. 2D echo establishes the diagnosis. This slide shows how it looks like in the 2D echo. Picture the image on your left side with the heart's apex at 9 o'clock position. Here you will see overriding of the aorta and a large ventricular septal defect. The pulmonary artery is not seen in this image. This is what it looks like when doing cardiac catheterization of a TOF. We usually do the cardiac catheterization if we want to determine the blood supply to both lungs, if the coronary arteries are crossing the right ventricular outflow tract, or if there is doubt of presence of both right and left pulmonary arteries. When tetralogy of Fallot correction is not done during the first 2 years of life, one of the most common problems that a TOF patient has is the paroxysmal hypercyanotic attacks, or what we call TET spells. It is an episodic central cyanosis due to the total occlusion of right ventricular blood flow. Some children will present with hyperpnea, worsening of cyanosis, gasping, or syncope. The mechanism of that spell is uncertain. Hypercyanotic spells may be triggered by activity, irritability, and prolonged crying, followed by hyperpnea, decreased in mean intrathoracic pressure, increased systemic compared to pulmonary flow, causing right to left shunting. The peak incidence is aged 2 to 4 months. A severe hypercyanotic spell may lead to limpness, seizures, and occasionally death. When faced with a patient with a TET spell, the first measure is to let the patient assume a knee chest or squatting position. This will increase systemic vascular resistance due to the kinking of major arterial circulation. When the systemic vascular resistance exceeds pulmonary vascular resistance, there is decreased right to left shunting and increased flow to the pulmonary artery. Increased oxygenated blood to the left ventricle decreases carbon dioxide, thus decreasing stimulation of the respiratory center, resulting to decrease in hyperventilation. One may give oxygen for whatever it's worth, since you already know the pathophysiology. Sedation is needed with administration of morphine. When the patient has severe cyanosis, he may develop metabolic acidosis, thus sodium bicarbonate may be given. The drug of choice in increasing systemic vascular resistance is phenylephrine. Propranolol with an unknown mechanism decreases the frequency of that spell. It is very important to intervene during the neonatal period when there is severe cyanosis. During this time, a patent ductus arteriosus may still be open after birth, where administration of prostaglandin maintains the patency of the patent ductus arteriosus. Or, PDA stenting may be done in the cath lab. When the pulmonary arteries are still too small, a Blalock-Taussig shunt may be done to increase flow to the lungs. Corrective surgery is done by closing the large ventricular septal defect with a patch and doing an infundibulectomy to widen the right ventricular outflow tract. When corrective surgery is successful, there is resolution of cyanosis and catch-up growth can be attained. Although corrective surgery may not be perfect and may have complications, such as right ventricular failure when too much of the muscle was incised, or transient heart block, or myocardial infarction when a coronary artery is incised. Our next topic is heart failure. Heart failure is when the heart is unable to pump sufficiently to maintain blood flow to meet the metabolic demands of the body. Cardiac output is dependent on the heart rate and stroke volume, or the amount of blood ejected from each ventricle. Heart rate is affected by the sympathetic nervous system, and stroke volume is affected by preload, contractility, and afterload. The pathophysiology of heart failure is governed by the Frank-Starling law, which states that when there is an increase in end-diastolic volume, there is also an increase in the cardiac output until a maximum is reached. The other principal mechanism would be cardiac output is directly proportional to the amount of blood going into the ventricles and inversely proportional to the resistance to which it pumps. Systemic oxygen transport is the product of cardiac output and systemic oxygen content. To better understand the pathophysiology of heart failure, we take a look at this Frank-Starling curve. When the heart is healthy, an increase in left ventricular end diastolic pressure also increases cardiac output until a maximum is reached. Then cardiac output cannot be augmented anymore. The increased stroke volume obtained in this manner is a result of stretching of myocardial fibers, but it also results in increased wall tension and an increase in myocardial oxygen consumption. Even in the presence of congestive heart failure, cardiac index increases until a critical left ventricular end diastolic pressure is reached. For example, with a congenital heart disease like a VSD, when the defect is big, the left ventricle becomes dilated due to the left to right shunting. So this increases preload and only making a little room for further dilation for an adequate cardiac output until heart failure ensues. Or when there is excessive afterload like that of severe aortic stenosis or coarctation of the aorta, cardiac output is compromised due to the high resistance to which the heart pumps. If there are structural malformations like that of an acquired heart disease such as myocarditis, the contractility is compromised due to the myocardial injury. The cardiac muscles requires a greater degree of dilation to produce increased stroke volume, but will not have the same maximal cardiac output as normal myocardium does. Heart failure can also occur due to non-cardiac causes. Remember that the systemic oxygen transport is the product of cardiac output and systemic oxygen content. The inability of the heart to meet the oxygen requirement of the body, despite the increase in cardiac output, can occur in severe anemia or in instances where there is increased oxygen demand, such as in sepsis or hyperthyroidism. An inadequate amount of oxygen is delivered to meet the body's needs. These conditions are examples of high output cardiac failure. Several compensatory mechanisms come into play to adapt to chronic heart failure, such as increase in sympathetic tone, which increases release of epinephrine from the adrenals, and increase in norepinephrine from the neuromuscular junction, thus increasing heart rate and myocardial contractility. These hormones may act on alpha-adrenergic receptors, causing constriction of vascular beds, more so that blood flow is redistributed from the cutaneous, visceral, and renal beds to the heart and brain. But the downside to this is that chronic sympathetic stimulation has detrimental effects since there is increase in myocardial oxygen demand. And there is also an increase in the afterload and increase in metabolism. Vasoconstriction can also decrease blood flow to the kidneys, the liver, and GI tract. And these are the reasons for the use of therapeutic agents for heart failure. These are the signs and symptoms of heart failure depending on the causes of heart failure. Those with congenital heart disease with left to right shunt, they may present with tachypnea, wheezing, rales, retractions, poor feeding, or irritability. Those with right-sided obstruction or increased right-sided filling pressure, they may present with right-sided heart failure such as hepatomegaly, ascites, pleural effusion, peripheral edema, weight gain, jugular venous distension. And those with impaired cardiac output or those patients with myocarditis, for example, they may present with tachycardia, cardiomegaly, gallop rhythm, decreased pulses, delayed capillary refill, and so on. This is how an X-ray of a patient with heart failure looks like. There is cardiomegaly, increased pulmonary vascularity, which is suggestive of pulmonary congestion. Depending on the cause of heart failure, the ECG may show chamber enlargement or hypertrophy, or it may show rhythm disturbances. Or there may be low voltage QRS, STT wave abnormalities, such as seen in myocardial inflammatory disease. Echocardiography determines cardiac structural malformation or abnormalities. It is also used to assess the contractility of the heart. Magnetic resonance angiography is useful in quantifying left and right ventricular function, volume, and mass, as well as coronary artery anatomy. The B natriuretic peptide may be elevated in those with systolic dysfunction and those with left to right shunts. The goals of treatment include the removal of the underlying cause. If the cause of the heart failure is a congenital heart disease, then surgery should be done if possible. Or if severe anemia is the cause, then correction of the anemia should be done. If surgical correction is not possible or if the cause cannot be removed, the medical management may be given to alleviate symptoms. The goal is to at least let the child be able to return to his usual activities. For those patients with pulmonary edema and with severe heart failure symptoms, intubation may be needed. Strict bed rest is necessary in those with extreme cases to decrease myocardial oxygen consumption. High back rest also alleviates orthopnea. Increasing daily caloric intake should be done due to an increase in metabolic state of those with heart failure. Before corrective surgery is done, or if corrective surgery cannot be done, medications are given to alleviate symptoms. Diuretics are the most important drugs since it decreases pulmonary fluid overload and ventricular filling pressure. Examples of these are furosemide, which is a loop diuretic, spironolactone, which inhibits aldosterone and a potassium-sparing agent, and of course, the ACE inhibitors, angiotensin II receptor blockers, which reduces ventricular afterload by decreasing peripheral vascular resistance and thereby improving myocardial performance. Digoxin is a cardiac glycoside that is used in those with chronic heart failure, those with decreased systolic function, and in those with atrial fibrillation. Triple therapy with digoxin, diuretic, and ACE inhibitor is associated with a low risk of worsening heart failure. The alpha and beta adrenergic agents are usually administered in the ICU setting. An example of this is dopamine. Dopamine has an inotropic and chronotropic effect. Phosphodiesterase inhibitors work by inhibition of phosphodiesterase that prevents the degradation of intracellular cyclic adenosine monophosphate. It is useful in those with low cardiac output who are refractory to standard therapy. Since you took up rheumatic fever and rheumatic heart disease, I won't be talking about it anymore. I will just discuss infective endocarditis and Kawasaki disease. Infective endocarditis is defined as an infection of the endocardial surface of the heart, which may include the heart valves, the mural endocardium, or a septal defect. There is a complex interplay of pathogen and host factors in the development of infective endocarditis. There is approximately 0.05 and 0.12 cases per 1,000 pediatric admissions from 2003 to 2010 in the United States. The high-risk groups are the intravenous drug users, survivors of cardiac surgery, patients on immunosuppressants, and patients on chronic intravenous catheters. Viridans type Streptococci or alpha hemolytic streptococci and Staphylococcus aureus remain the leading causative agents for endocarditis in pediatric patients. Alpha hemolytic strep is common in those with congenital heart disease. Staphylococcus endocarditis is more common in patients with no underlying heart disease. Group D enterococci is a cause of IE after lower bowel or genitourinary manipulation. Pseudomonas aeruginosa is a cause of IE in those with IV drug users. And coagulase negative staphylococci is a cause for IE in those with indwelling central venous catheters. Infective endocarditis is often a complication of congenital heart disease and rheumatic heart disease. The development of endocarditis usually entails an abnormal substrate and a bacterial source. Like for those with congenital heart disease or rheumatic heart disease, what happens is that there is sloughing off of the endothelium due to the jet of blood from the defect from the regurgitation. This creates a substrate for deposition of fibrin and platelets, leading to the formation of a non-bacterial thrombotic embolus. Biofilms form on the surface of the implanted mechanical devices such as valves, catheters, or pacemaker wires. Transient bacteremia then colonizes this non-bacterial thrombotic embolus or biofilm. Bacteria then proliferate on the lesion. These are the clinical manifestations of infective endocarditis. Usually in the history, there is congenital heart disease or rheumatic heart disease with prior dental or gastrointestinal procedure. 80 to 90% of them will present with prolonged fever. And 40 to 50% will have heart failure, and about 40 to 50% also with petechial rash, and some may present with splenomegaly, Osler's nodes, splinter hemorrhages, petechial hemorrhages on mucous membranes, Roth spots, and systemic emboli. Lab results may show positive culture of typical organism, elevated ESR in 70 to 80% of patients. Infective endocarditis is diagnosed using the Dukes criteria. The first major criteria includes 2 positive blood culture of a typical organism, persistent positive blood cultures taken 12 hours apart, 3 or more positive blood cultures taken over 1 hour apart, and this is why 3 to 5 separate blood collections should be done when suspecting infective endocarditis. When the patient was already started with antibiotics, the laboratory should be informed since it reduces the yield to 50 to 60%. The second major criteria is the endocardial involvement documented by positive echocardiac findings of vegetations or presence of new valvular regurgitation on 2D echo. The combination of transthoracic and transesophageal echocardiography enhances the ability to diagnose endocarditis. Two-dimensional echocardiography can identify the size, location, and mobility of the lesion. When combined with Doppler studies, the presence of valve dysfunction can be determined and its effect on left ventricular performance quantified. When lesions greater than 1 centimeter and there is detection of fungating masses, these are at greatest risk for embolization. A modification of the Dukes criteria may increase sensitivity while maintaining specificity. And this is the reason why they have increased the number of minor criteria. So there are 9 minor criteria, and you can just read this one. So the diagnosis of infective endocarditis requires 2 major criteria or 1 major criterion and 3 minor criteria or 5 minor criteria. Those with possible infective endocarditis may have 1 major criterion and 1 minor criterion or 3 minor criteria. Treatment for infective endocarditis is 4 to 6 weeks in duration. And for those with native valves, the antibiotic used is penicillin G or vancomycin plus gentamicin. And those with prosthetic valve, uh, vancomycin plus gentamicin is used. Mortality rate is as high as 20 to 25% despite antibiotic treatment. Serious morbidity is 50 to 60% among those diagnosed with infective endocarditis. And the most common morbidity is due to the heart failure. Diagnosis and treatment should be instituted due to the many complications of infective endocarditis. Listed on the slide are the complications that may be encountered. There are indications for surgery in those with bacterial endocarditis. These are aortic or mitral infective endocarditis with severe acute regurgitation or valve obstruction causing refractory pulmonary edema or cardiogenic shock, aortic or mitral infective endocarditis with fistula into a cardiac chamber or pericardium causing refractory pulmonary edema or shock, aortic or mitral infective endocarditis with severe acute regurgitation or valve obstruction and persisting heart failure or echocardiographic signs of poor hemodynamic tolerance, aortic or mitral infective endocarditis with severe regurgitation and no heart failure. Another indication is uncontrolled infection, and the other is aortic or mitral infective endocarditis with large vegetations of greater than 10 millimeters following 1 or more embolic episodes despite appropriate antibiotic therapy, aortic or mitral infective endocarditis with large vegetations greater than 10 millimeters and other predictors of complicated course like heart failure, persistent infection, and abscess, isolated very large vegetations of greater than 15 millimeters. So when do we give antibiotic prophylaxis? Before, we give antibiotic prophylaxis to all patients with congenital heart disease. But now, we only give antibiotic prophylaxis to those with prosthetic cardiac valves, those with previous infective endocarditis, recipients of cardiac transplantation with valve regurgitation due to structurally abnormal valve, those with unrepaired cyanotic congenital heart disease, including palliative shunts and conduits, those with completely repaired congenital heart disease, repaired with prosthetic material or device, whether placed by surgery or catheter intervention during the first 6 months after the procedure, or repaired congenital heart disease with residual defects at the site or adjacent to the site of the prosthetic patch or prosthetic device. Prophylaxis against infective endocarditis is not recommended in patients with um, valvular heart disease who are at risk of IE for non-dental procedures. Another name for Kawasaki disease is mucocutaneous lymph node syndrome. Kawasaki disease is an acute, self-limited febrile illness of a known cause that predominantly affects children less than 5 years of age. The most common cause of acquired heart disease in developing countries is rheumatic heart disease. But in developed countries, the most common acquired heart disease is Kawasaki disease. It is characterized by systemic inflammation in all medium-sized arteries and multiple organs and tissues during the acute febrile phase. The cause is still unknown, but was hypothesized that the trigger is a viral infection because the peak coincides with the seasonality of common respiratory infections. Coronary artery aneurysm from Kawasaki disease affect adult life, accounting for 5% of acute coronary syndromes in individuals less than 40 years of age. The estimated incidence in North America is 25 cases per 100,000 for less than 5 years of age. There is a male preponderance of the disease with the highest risk among Asian children. Vasculitis begins with neutrophil infiltration of the arterial wall that occurs during the first 2 weeks of the disease and destroy the vascular wall, causing aneurysms. This is the first phase, which is the necrotizing phase. Thereafter, there is a lymphocytic infiltration with T cells, plasma cells, and monocytes releasing pro-inflammatory cytokines, interleukin 1B and TNF alpha, and this may continue for months to years in some patients. This is the second phase. The third phase is the proliferation of myofibroblasts in the arterial wall during the chronic phase, leading to vascular lumen stenosis. Diagnosis of Kawasaki disease is considered in those with fever at least 5 days and at least 4 out of 5 of the principal features. The first criteria is the erythema and cracking of lips, strawberry tongue, and or erythema of oral and pharyngeal mucosa. The second is bilateral bulbar conjunctival injection without exudate. Third is a maculopapular rash, diffuse erythroderma or erythema multiforme-like. Fourth is erythema and edema of the hands and feet in acute phase and or periungual desquamation in the subacute phase. Fifth is cervical lymphadenopathy of greater than or equal to 1.5 centimeter in diameter. So diagnosis of Kawasaki disease is considered when there is greater than or equal to 5 days of fever plus 4 out of 5 of the criteria. So these are the other clinical presentations of Kawasaki disease. So some of the patients may present with hepatitis, interstitial pneumonitis, gastrointestinal tract symptoms, meningitis, pancreatitis, pancreatitis. There are three clinical phases of Kawasaki disease. The first phase is the acute phase, which is about 1 to 2 weeks. And during this phase is when you have fever and acute signs of illness. The second phase is the subacute phase, which occurs about 10 to 25 days after the onset of fever. And in this phase, you see desquamation, thrombocytosis, development of coronary artery aneurysm, and sudden death. And the third phase is the convalescent phase, where signs and symptoms disappear and until the ESR is normal. Incomplete Kawasaki disease should be considered when an infant or child has prolonged unexplained fever with fewer than 4 of the principal findings. So how do you evaluate a suspected incomplete Kawasaki disease? First is you obtain ESR and or CRP. When it is elevated, draw blood and check for anemia, thrombocytosis, hypoalbuminemia, elevated ALT level, leukocytosis, and send urine for urinalysis. And if you have greater or equal to 10 white blood cells per hyperpower field and you're able to get 3 or more of these laboratory findings, then most probably you have incomplete Kawasaki. Or if you have positive echocardiogram, which shows coronary artery dilatation, coronary artery ectasia, or aneurysm, then consider incomplete Kawasaki. If CRP and ESR is low, you may have serial clinical and laboratory evaluation if fever persists, and you may do echocardiogram. But if results are negative, then consider another differential diagnosis. Commonly, there is normal or elevated WBC, elevated CRP and ESR, hyponatremia, hypoalbuminemia, elevated serum liver enzymes, pyuria, and thrombocytosis. ECG may show malignant ventricular arrhythmia, prolonged PR interval or first-degree AV block, and nonspecific STT wave changes. You may also see low voltage QRS and left ventricular hypertrophy. Echocardiography is primarily focused on detection of coronary artery dilation and aneurysm. There may be left ventricular dysfunction or ventricular systolic and diastolic dysfunction. It is also used on evaluation of regional wall motion, presence of pericardial effusion, and valvular regurgitation. Myocardial involvement of Kawasaki disease may be pancreatitis, which may include the endocardium, myocardium, and pericardium. On physical exam, there may be dynamic precordium, tachycardia, gallop rhythm, pericardial rub, and murmurs. Primary treatment to Kawasaki disease is giving IVIG 2 gram per kilogram as a single infusion over 10 to 12 hours, together with aspirin 80 to 100 milligram per kilogram or 30 to 50 milligram per kilogram, and decreased to 3 to 5 milligram per kilogram after 48 to 72 hours, being afebrile. And this low dose is given for 6 to 8 weeks. Other adjunctive treatment for Kawasaki disease are methylprednisolone, infliximab, and etanercept. Predictors of poor outcome include young age, male, persistent fever, poor response to IVIG, presence of neutrophilia, thrombocytopenia, transaminitis, hyponatremia, hypoalbuminemia, elevated levels of N-terminal brain natriuretic process, elevated CRP. IVIG resistance occurs in 10 to 20% of patients, and it is suspected when fever persists at least 36 hours after the end of their IVIG infusion. There is increased risk for coronary artery aneurysm in these patients. With IVIG resistance, a second dose of IVIG may be given, or IVIG plus prednisolone, or infliximab. Other alternative treatments include cyclosporin, anakinra, cyclophosphamide, or plasma exchange. Timely treatment reduces risk of coronary artery aneurysm by less than 5%. Acute Kawasaki disease recurs in 1 to 3%, and the fatality rate is 1.3%. 50% of coronary artery aneurysm regress to normal lumen by 1 to 2 years after illness. The coronavirus pandemic is associated with increase of incidence of Kawasaki disease. This led to the support to the viral etiology of Kawasaki disease. Initially, it was reported that SARS-CoV-2 affected children only with mild symptoms, but there were outbreaks of severe multisystemic inflammatory disorders. Multisystem inflammatory syndrome in children, or MIS-C, is a cytokine storm induced by COVID-19 virus. It shares features of staphylococcal aureus toxin-mediated toxic shock syndrome and atypical Kawasaki disease. It is, an, it is a multi-organ dysfunction and has a high incidence of myocarditis. It has high inflammatory markers like CRP, procalcitonin, interleukin 6, interleukin 10, ferritin levels, and D dimers. Clinical features of MIS-C include high fever, rash, conjunctivitis, edema, abdominal pain, diarrhea, vomiting, cardiovascular shock. So, how do we differentiate MIS-C and Kawasaki disease? Usually in MIS-C, the age group is broad. There is more gastrointestinal involvement. There is lymphopenia and thrombocytopenia. Usually there is myocarditis and cardiogenic shock. There is coagulopathy, elevated interleukin 6, 10, ferritin, soluble interleukin 2 receptor. However, in Kawasaki disease, usually it occurs in early childhood or less than 5 years old. There is less gastrointestinal involvement. Usually, cardiac involvement is pancarditis, or it involves the endocardium, the myocardium, and pericardium. And usually there is thrombocytosis. There is actually no standard treatment for MIS-C, but many patients receive IVIG, usually with methylprednisolone, 1 to 4 milligram per kilogram per day. The others receive remdesivir, and some patients receive low-dose aspirin and enoxaparin. So that is my last slide. I hope that you have learned and understood my lecture. So I have discussed to you the fetal circulation and its transition to neonatal circulation. Um, I have already discussed to you how to evaluate suspected patients with congenital heart disease. We have discussed ventricular septal defect, patent ductus arteriosus, and tetralogy of Fallot. And I have also taken up heart failure and the other acquired heart diseases such as Kawasaki disease and infective endocarditis. Thank you for listening.